Good morning. Good morning. Thanks for coming. We're going to see, are you all comfortable in the back like that? You don't want to sit up front? Okay. All right. We're waiting for everyone to get here. Wait a few more minutes. Okay, good morning. I'm Dr. Harolyn Belcher, and I wanted to welcome you to the Room to Grow Journey to Cultural and Linguistic Competency Conference for 2017. Really appreciate you all coming and being here and participating. And this is their 7th conference that we've had, and it was especially designed for you all. So we thank you for that. And really, I think this is kind of a challenging time as we struggle with health equity and diversity and inclusion. And in this space, we hope to promote open communication and respect for differing ideas. We want to practice engaged and active listening. And so at this point, what I'd like you all to stand up as you're able. Can you all stand up? And then I wanted you to close your eyes and think for a moment about those who have gone before us and paved the way for us to have these talks. I wanted to think a little bit and have positive thoughts for those who are suffering in Puerto Rico and the Caribbean at this point in time, Texas and Florida. So we're thinking about those who are less advantaged than we are, those who have experienced not this openness that we hope to have here today in Charlottesville, those in Charleston, and those even in Baltimore. We want to kind of think about those individuals and how we provide care, service, and partnership with those in the community. So I'd like to thank our sponsors, and that's Hopkins Office of the Provost, the MCDD, the Maryland Center for Developmental Disabilities, the LEND program, and the Hopkins Center for Health Disparity Solutions. You all may sit down. Just have to be a little grateful and about where we are at this point in time, so I thank you for that. So let's learn from what we hear and do today so that we may use health equity and culturally competent strategies to celebrate diversity and inclusion and to practice advocacy. So this is not a one and done, but a journey. So I hope you all will gain some new skills, new ideas that you will take forward as you work with families and care for children. So I would like to, at this point, turn the podium over for a welcome to Dr. Bruce Shapiro, who you all know as the Vice President of Training at Kennedy Krieger Institute. And I will do that at this point. So thank you.
Thank you and good morning. Good. I'm glad everyone's awake. Why is everyone sitting in the back? I know there's good sound in this auditorium, but those of us who are speaking in front feel a little bit lonesome. I'd like to welcome you to the 7th annual Room to Grow conference. This is, as subtitle, A Journey to Cultural and Linguistic Competency. And I think that in the 7 years that I've been attending this conference, it's been interesting to see how the conference has evolved. The initial years of the conference were focusing on how practitioners interact with people of different cultures and to make us more aware of those differences in an effort to enable us as practitioners to be able to deliver better care to the families that we serve. As the conference has evolved, it's taking on an added dimension and has moved from focusing on the practitioner-patient interaction to a broader interaction and focusing on issues relating to social determinants of health and health disparities. This has been an important focus, and one of the practicalities of that focus is to understand that your life expectancy in Baltimore depends on the zip code in which you live. There are marked differences in life expectancy depending on what part of the city you live. And this is just one example of the disparate outcomes that we see in health. So that a decision was made a number of years ago to add a dimension that enables us to deal with things not so much at the provider-patient interaction, although that is very important, but to begin to provide a background for people to begin to understand how we have to affect systemic change in an effort to change what is a very distressing set of outcomes for certain parts of our population. Today is a day where there'll be two parts to this conference. One part of focusing on faculty members, and the other part will be focusing on trainees. The morning, it will be an overall set of plenary sessions, and the afternoon will be where there'll be much more devoted to those two groups. I encourage you to stay for the whole day and to take full advantage of the opportunities that are going to be presented to you. This is a wonderful conference, and I hope that you will enjoy it as much as I have over the past 7 years. So thank you very much, and welcome again.
Okay, so So it gives me great pleasure at this point to introduce Dr. Marshalyn Yeargin-Allsopp, who is the Associate Director, Children with Special Healthcare Needs, Division of Congenital and Developmental Disorders, National Center on Birth Defects and Developmental Disabilities for the Centers for Disease Control and Prevention. And she will be speaking to us today about what can CDC and population data tell us about health disparities and disabilities.
Good morning, everyone. Good morning. I am very pleased to be here today to present to you on what can CDC and population data tell us about health disparities and disabilities. I want to just pull this up on the screen here for me. So it's the, I want to see the slideshow on here. Let's see. Did that do it? I want the slideshow. And while Dr. Belcher is doing that, I want to thank her and the organizers of this conference for inviting me, and for Dr. Belcher for all her organization and her passion about the conference. Yeah, I don't know why. Should I do something?
This is what they see. They only see this.
I know, but I was trying to. That's okay.
Is that a-
Slide now. Normal. Okay, it's okay. See, so it's kind of small for me to read. That's what I was looking for. Slideshow. That's slideshow. Does that do it? No. Okay, we will just move on. If I can find it. See, it's, with the print would be small for me, so I wanted to. Oh. Mm-hmm. So let's go to the next one. So, that doesn't advance it, does it? Usually when you do that,
I don't know. It's good enough.
That's
Now
good
you
enough.
can see the slide before.
right, okay. Thank you very much, Dr. Belcher, our AV technician. All right, so I think we're ready to go now, and I have nothing to disclose. So today I'm going to talk about which groups of children are more likely to have developmental disabilities, and developmental disabilities is abbreviated as DDs, obviously. Talk about whether children with developmental disabilities have differences in health outcomes, and not just children, but what about adults as well? What about individuals with disabilities overall? Talk about CDC's role in addressing health disparities, and then conclude. So I have several sources of data that I've used for the presentation. So I'm going to explain now what these data sources are, so you'll be aware of this as I go through the slides. So the first is CDC has several surveillance programs, and another word for surveillance is monitoring or tracking of disabilities. We have the Metropolitan Atlanta Developmental Disability Surveillance Program, which was our first project in Metro Atlanta, 5 counties of Metropolitan Atlanta, and it is the model for our larger project, which is across the United States with multiple sites, and that is the Autism and Developmental Disabilities Monitoring Network. Both of these surveillance programs identify children at age 8 with autism, spectrum disorder, and other disabilities. They are ongoing surveillance systems, and I will describe them more briefly throughout the presentation. The second source of data that I want to mention is a cooperative effort between CDC and HRSA, and we sponsor several nationally representative surveys of children. One of them is the National Health Interview Survey, and the other one is a national survey on children's health. I'll be talking about some results from those surveys as well. And the last data source I want to mention is an ongoing nationally representative survey of adults. So, some orientation. You've heard the word social determinants of health. What does that mean? It means conditions in which people are born, grow, live, work, and age. WHO has a definition that says that social determinants of health are shaped by the distribution of money, power, and success, and access to resources. Social determinants of health contribute to health inequities that are unfair and avoidable differences in health status. There are common indicators of health status. How do we measure this? What are we talking about when we talk about social determinants of health? There are 2 terms that we use. The first is prevalence, which is all existing cases, old and new, in a population. And the second is incidence, which is newly diagnosed cases. For children and adults with disability, we usually refer to prevalence rather than incidence. What factors contribute to health status? I'll ask you a question. Is health purely biologically determined? I hope you know the answer is no. The more we learn, the more we understand the contributions of social determinants of health. An example of a social determinant of health that is often examined is socioeconomic status, or SES. And SES is often defined as a combination of occupation, income, and education. For example, for children who are lower SES, they have at least twice the risk of a number of medical outcomes, including asthma, epilepsy, mental health disorders, and developmental delay. This is well documented in the literature. I'm now going to talk about which groups of children are more likely to have developmental disabilities. On the slide are some commonly studied developmental disabilities, and I'm going to talk about autism spectrum disorder, or ASD, cerebral palsy, which is abbreviated as CP, and intellectual disability, which is ID. And there are some others that I've listed here. They're not the major focus of my presentation today. I'm going to give you some definitions so that as we talk about these, that you will know what I'm referring to. So autism spectrum disorder, or ASD, refers to impairments in social interaction and social communication, along with restricted interests and repetitive behaviors. Cerebral palsy is defined as a group of non-progressive disorders of movement and posture causing activity limitation attributable to damage or disturbances that occurred during the developing fetal or infant brain. Intellectual disability refers to significant limitations in both intellectual functioning and adaptive behavior, which includes daily social and practical skills. And this has to occur before the individual is age 18. Now here we have a map of CDC's Autism and Developmental Disabilities, or ADDM, network sites. These are the sites for 2010 and 2012. There were 11 sites. They're all colored in. And the sites participate with CDC through a cooperative agreement. It was a competitive process. And so I'm often asked, why not California, Texas? What about some of the states that are missing? But these are states that applied for funding from CDC and were funded based on a competitive outside review process. There were 11 sites. All the sites are required to identify children at age 8 with autism spectrum disorder, and they can also identify children with the other disabilities, hence the different colors. We also had a number of sites that they use the same methods to identify children at age 4. So that's the two-stick person is the sites that we're identifying children at age 4 and 8, and the one-stick person, so identification of individuals at age 8. And the different colors, as I said, represent whether the sites were doing just ASD. There were 6 sites that were doing ASD and intellectual disability, and there are 4 sites that were identifying children with ASD and CP. Our flagship site in Atlanta does 5 disabilities, and you'll see a slide on that. And they are ASD, CP, ID, hearing loss, and vision impairment. So before I talk about the specifics related to these disabilities, let's look at trends in prevalence among children with Dds overall. And this information comes from the National Health Interview Surveys from 1997 to 2008. And what I want you to notice is that first line that says any developmental disability. The prevalence in 2008 was close to 14% of children, which is significant. 15% of children have some type of developmental disability. But what I also want you to note is this percent change in the prevalence over time. So during this time period, the prevalence of any disability increased about 17%. Now you can quickly look down this list, and one of these disabilities kind of stands out, doesn't it? And we know a lot, and there's been a lot in the news about this increased prevalence in ASD, and you see that it was almost 290% increase over time. So this is very similar data from metropolitan Atlanta, where, as I said, we ascertained 5 developmental disabilities. Even if you can't beat all the numbers, what you can notice is the trend line. And what you see is for 4 of these 5 disabilities, it's relatively flat. Maybe it's decreasing a little bit in terms of CP. But that red line that just, skyrocketing, that is the prevalence of ASD. And again, in metropolitan Atlanta, when we look at disabilities overall by survey data, we look at ADAM data, there's a consistent pattern of an increased prevalence in ASD over time. So let's talk about autism spectrum disorder. The overall prevalence in 2012 was our most recently reported data, was about 14.6 per thousand, or 1 in 68. I'm sure that everyone knows that number. I should have asked you. But everyone has heard the 1 in 68 children have ASD. And these are children that are 8 years old in 2012, so that means they were born in 2004. So what do we know about the sex differences in terms of ASD? And I think you all are probably all familiar with this. Boys were 4.5 times more likely to be identified with ASD than girls, and this is a bar chart that represents that. Boys with ASD were also more likely to be identified with ASD at a younger age. What about girls with ASD, especially those without cognitive impairment? They may be formally identified at a later age than boys, and so we ask, why is that the case? Is that some cultural bias? Is it that parents aren't identifying girls without intellectual disability who have the features of ASD? Or is this in the eyes of the clinicians? Are we as clinicians not recognizing girls at a younger age compared to boys? This information looks at maternal education and family income. So skip to the bottom part of this table and let's look at median family income level. And this is the risk of autism with and without intellectual disability. The first column are the cases without intellectual disability, and the second are the cases of autism with intellectual disability. And what we see is this number is over 1. 1 is the reference. This is the baseline. And anything over 1 means that there's an increase. So this means that families with a high income have an increased risk of having a child with autism with or without intellectual disability. Now, interestingly, at the first part of the table is looking at maternal education, and we don't see the same thing. We don't see the same pattern. We see that if the mother has more than 16 years of education, that the risk of autism without intellectual disability is increased, but the risk of autism with intellectual disability is not. So we find that very interesting in terms of the role of maternal education. This is very similar data published in 2010, and it's looking at socioeconomic status and looking again at the risk of having ASD. So SES is defined as maternal education, and what we see, middle is the reference group, and with high, we see that there's an increase in the prevalence. And again, this means that these are mothers who have a higher degree of education. So the ASD prevalence increased with increasing SES in a dose-response manner. We were able to show that in the paper. The stronger SES gradient in ASD prevalence in children with ID versus no ID was shown before. But in this instance, we were looking at children who had a diagnosis of ASD earlier as opposed to children who had a diagnosis of ASD later. And we saw that this increased risk was in those children who had a diagnosis earlier as opposed to those that had a diagnosis later. So again, thinking through this, what is the reason? We are thinking maybe this is an ascertainment or some type of diagnostic bias. Or perhaps the SES disparity is related to access to services. This looks at race and ethnicity, and we've been able to look at that with our ADAM data because we have a lot of heterogeneity in terms of our population. And what we found is that white children were more likely to be identified with ASD than black or Hispanic children. Black children were more likely to be identified with ASD than Hispanic children. And this is represented here with the bar charts. We also did a study. We looked at community identification in metropolitan Atlanta. And we found that black children were more likely than white children to have a diagnosis of autistic disorder documented in their records. And at that point, we were looking at the 3 subtypes of ASD, which are autistic disorder, pervasive developmental disabilities not otherwise specified, and Asperger disorder. And although we don't like to talk about severity in terms of ASD, it is clinically understood that children with autistic disorder sometimes are more, quote, severe than children with PDD, NOS, and Asperger disorder. So what we found, as I said, is that the black children were more likely than the white children to have the diagnosis of the more severe type of ASD. And they were less likely to have the diagnosis of the milder types, the PDD, NOS, and the Asperger disorder. How might we address those potential causes of differences? Again, looking at the data that we found in metropolitan Atlanta, we can reduce cultural barriers to accessing diagnostic and intervention services among the minority children with ASD, and minority here was black and Hispanic. We can increase awareness amongst clinicians and health educators like you. We can identify culturally sensitive screening and assessment practices and specifically focus on educating parents on the subtle signs and examples of ASD. So the bottom line is disparities in ASD prevalence related to sex, race, ethnicity, SES may indicate that some children are not receiving appropriate services and support. And we can say that because that's how we identify these children with ASD. They come into either a health or an education service environment, and so we're capturing the children who are accessing services as part of our surveillance system. Regardless of that, many children and families living with ASD need services and supports now as they grow, particularly as they grow into adolescence and adulthood. And any of you who are familiar with the conversation about ASD now realize that there's a lot of conversation about transition, about the services for adults, and so we go beyond just what's happening in childhood, and these children are growing up, and the services are often not available for them. So moving on to cerebral palsy. CP is not as common. The overall prevalence is about 2.9 per 1,000. And this information comes from the 4 Adam sites that were represented on the map that I showed you. Our most recently published data are from 2010. These children were 8 years old, were born in 2002. And for ease, we translate this as 1 in 345 children have CP. So this slide is looking at race and ethnicity from the Adam network, and we were looking at all of our data points 2002 to 2010. We had a small number of cases in 2004. It was a different year for us, and so we didn't report the data for 2004. But I just want you to look at the black non-Hispanic line versus the white non-Hispanic line. And it doesn't take much to realize that the prevalence in black children is consistently higher than the prevalence in white children. And we've been tracking cerebral palsy in metropolitan Atlanta since the 80s, and that has been consistently found in our data. So we wanted to drill down and understand a little bit more about these black children that have the higher prevalence of cerebral palsy. So we wanted to think about, what about the severity? What about their functioning? And there is a scale known as the Gross Motor Function Classification System that identifies children in terms of severity of CP by their ability to walk or not walk. So levels 1 and 2 represent children who walk unassisted, and GMFCS level 3 are children who walk with assistance, And levels 4 and 5 are children who have limited or no walking ability. They are often in wheelchairs. So if 1 is our baseline, and this is looking at the ratio of the prevalence of black children to white children in terms of severity, what we see is that this increases according to the level of severity. So that when we are at levels 4 and 5, we see that black children have overall twice the prevalence in terms of their ability to walk compared to white children. So overall, the black children are more severe, and this is a way of documenting that. So what are some of the potential mechanisms? Are there real differences in risk factors? What would these risk factors be? What about access to interventions? Is that different? Is there an under-identification of mild CP in black children? These are all our questions. We don't have answers. So moving on and looking again at socioeconomic status, we wanted to look at socioeconomic status and perinatal factors in these racial ethnic disparities that we see in cerebral palsy. So we had 3 hypotheses. The first was the risk of CP declines with increasing socioeconomic status. The second is the observed racial ethnic disparity in CP risk is due to confounding or is mediated by racial ethnic disparities in SES. And the third is perinatal factors, preterm birth and small for gestational age mediate the association between race as well as maternal education and CP risk. So this slide sums up our ability to look at these 3 hypotheses. So the first is just unadjusted, and we've already talked about the fact that black children have a higher prevalence than white children. It's about 50% higher according to this data, and this is only looking at spastic CP. Some of you may know that CP has different subtypes, but when we looked at this by spastic and non-spastic, there were more differences related to spastic CP. So in the paper, we describe all children, regardless of subtype, but I'm just focusing on the children with spastic CP here. So we adjusted for SES, and SES was measured by maternal education at the time of the child's birth. And so we adjusted for maternal level of education, and what we found is it didn't go away. So we still see this difference in terms of the prevalence in black children compared to white children. And we adjusted again, because some of you may know about the risk of CP due to low birth weight and being small for gestational age. And these factors are higher in black children than white children. So, of course, we want to adjust for that and see if we can make it go away. And we do. So when we add these perinatal risk factors as part of the adjustment, what we see is actually the risk is lower for black children and Hispanic children than it is at baseline, which is really interesting and makes the point that if we want to make progress in terms of reducing the prevalence of CP overall, we need to identify these risk factors related to these perinatal risk factors related to low birth weight and preterm birth and make an impact there. And most of you know that although we've been working on this for a number of years, we've not made enough progress there when it comes to particularly black mothers and their risk of having babies at a low birth weight and preterm. So if we want to summarize these 3 hypotheses, so the first is that the risk of CP declines with increasing SES. We have a green light there because we did demonstrate that. The second is the observed racial ethnic disparity in CP risk is due to confounding or is mediated by racial ethnic disparities in SES, and our measure of SES was maternal education, and it didn't go away, did it? So we have a red light there. And our third hypothesis is a little more complicated. There are 2 parts of this. So the first part is perinatal factors, preterm birth, and small for gestational age mediate the association between race as well as maternal education and CP risk. So it did reduce the risk when we added those perinatal risk factors, but maternal education did not reduce this completely. So we have a yellow light there because we can't say, we can't give it a green light for for all of those factors. So further research can help us answer some of these questions. The questions are related to causal mechanisms underlying associations between low SES and spastic CP. What about the effects of other components of SES? I mentioned income, I mentioned education, I mentioned occupation, but what are other factors that are related to SES that we can't measure or haven't measured as part of our evaluation there, like insurance coverage and other factors, and for our analysis we did not look at income and occupation. What about longitudinal trajectories? So can we evaluate the direction of the association between CP and SES? Does this continue over time, or is this only occurring at the time of the child's birth? And we were not able to look at this in a longitudinal fashion. Our public health goal is to reduce the risk of CP in the population overall to the level of risk experienced by the offspring of college-educated mothers, right? So it looks like if we could just get all those mothers more educated, that it would actually reduce the risk of CP, of a health outcome. So here is the point related to social determinants of health, right? So how might we achieve this goal? So in summary, racial ethnic disparities exist among children with CP. Black children with CP are more likely to have limited or no walking ability. We demonstrated that. Black children are more likely to have spastic CP after we control for SES. However, the association between Black race and excess CP risk seems to be accounted for by preterm birth and associated perinatal factors, and I've already discussed that. Maternal education overall seems to be a protective factor in terms of CP risk. We demonstrated that, and further research could help us understand these disparities and inform our prevention strategies. So let's move on to intellectual disability. The overall prevalence is about 1.5%, 15 per 1,000. The range in terms of our Adam sites, and it was in 3 Adam sites, was between 13 and 20 per 1,000. The children are always 8 years old. We use Adam data. These children were born 1994, 96, and 98. And so if we use our more convenient way of thinking about what this means, it is an estimate of 1 in 91 8-year-old children in metropolitan Atlanta had an intellectual disability. So we can look at this by sex, and we have demonstrated consistently that there's a slightly higher prevalence in boys compared to girls. It is similar for mild and moderate to profound intellectual disability, and many of you are familiar that there are different levels of functioning related to intellectual disability, and that's based on IQ test score. But the real difference we wonder, we don't know, or the social factors, are they affecting identification? Again, a child has to be tested and have an IQ test score for us to count them. So it gets back to access and issues of testing. The higher prevalence in boys may be associated, and you may be thinking about this, with some genetic conditions, such as Fragile X syndrome, and there are others that seem to be higher in boys compared to girls. 13 to 21% of intellectual disability in males is attributed to X-linked disorders. And the differences are more pronounced for the children that are in the moderate to profound ID range versus those with milder ID. So this is from a paper that we did a long time ago now. We looked at mild intellectual disability and other levels in Black and white children. And we found that mothers of children with mild intellectual disability were more likely to be Black. The excess prevalence, and we tried to reduce this difference by controlling for sex, maternal age at delivery, birth order, maternal education, and economic status. And it was reduced, but it didn't go away. It was reduced by almost 50%. There was little difference in prevalence of mild intellectual disability between Black and white children diagnosed before reaching school age. Again, something happens early on, whether you're talking about ASD or intellectual disability. There seems to be a different pattern of identification in younger children compared to older children. The racial ethnic disparities in prevalence of mild intellectual disability may be affected by And we talk about this in the paper. What about environmental exposures, maternal health conditions? What about intergenerational poverty, maternal cognitive level, and the early cognitive experiences of children? We are not able to measure those, but we wonder about the impact of those factors on this difference. Education, occupational, and income have been consistently linked to performance on measures of IQ. Cognitive development is highly dependent on adequate sensory, emotional, and social stimulation during critical developmental periods, and I know that we are focusing more on this now than we did then. We understand more about early brain development and the impact of the environment and the experiences that children have at young ages. And we know that there is a critical time in terms of overall development, particularly cognitive development, and we have to really seize the opportunity to enhance the development of all children during these critical times of development. We know more about the consequences of an impoverished environment. We know that neighborhood disadvantage constrains parenting practices and restricts achievement. And we have a lot of literature that shows that a higher SES is consistently associated with higher general cognitive ability. We don't know exactly all the components of that, but that has been well documented. What about severe ID? And these are children who have the moderate, severe, profound level of intellectual functioning. In high-income countries, in children, the range is 3 to 5 per 1,000 children. And it's not surprising that in low-income countries, it's much higher, 2 to 3%. And we can all, list some factors that we think are responsible for this higher prevalence of severe ID in less affluent countries. Poverty and socioeconomic deprivation contribute to the causation of ID by increasing the risk of many of these known causes of ID. And we have insufficient exposure to early cognitive and socio-emotional stimulation in many of these countries. We don't have early intervention there, and so we know that many of these children are not getting the stimulation that they need early in life. So moving on, do children with developmental disabilities? We've identified this pool of children with DDs, but do they have differences in their health outcomes? And then what about people overall with disabilities? So people with intellectual and developmental disabilities as a group do have higher rates of adverse health conditions, and this has been documented with looking at a number of health conditions: epilepsy and neurological disorders, gastrointestinal disorders, behavioral and psychiatric problems. In fact, there are not many, if any, health conditions that I can think of where you don't see this increased risk in individuals who have a developmental or have a disability. This is compounded by disparities in use of preventive care and engaging in healthy behaviors. There's a substantially higher risk of obesity and other chronic conditions, and a lot has been talked about related to obesity per se. So here's an example of concurrent medical conditions in children with developmental disabilities, and this information came from one of those national surveys that I mentioned that CDC and HRSA work on together. So compared to children without DDs, children with DDs had a higher prevalence of a range of medical conditions, are more likely to have asthma, 3 or more ear infections, frequent diarrhea, colitis, frequent severe headaches, migraines. And in addition to these health problems, these children as a group also have unmet needs. They're more likely to have delays in care, to be unable to afford needed prescription meds, etc. You can just imagine there are many unmet needs. Even children with DDs that we consider less pervasive and less severe, let's take ADHD or learning disability, we don't think of those as being as severe ID or ASD. They still have an increased risk for many common health conditions. And could this be an indication of health disparity? Is this due to a difference in access to care? So here's an example You know, we're all very aware of our obesity epidemic. CDC makes us aware of this with beautiful charts with colors changing rapidly as we move from the proportion of the population, you know, that are within the normal range of weight, moving to the individuals that are overweight to the individuals that are obese. And we have seen how this has changed over time. So we're looking at unhealthy weight among adolescents with DDs. And if we look at those adolescents we're looking at obesity now, and we look at those without developmental disabilities, it's not a good percentage. It's 13%, but that's what it was at this time. But if we look at children with any learning, behavioral, or developmental disability, it's 20%. If we look at those children with autism, it's a whopping almost 32%. So we can look at those numbers and realize that if you have a developmental disability, that you have an increased risk for obesity. We're not quite sure why, but this is what our data are telling us. So we can also look at differences in life outcomes. Again, we can move from childhood to adulthood, and what we see is that profound adverse impacts of ID on individuals and their families. So in mothers who have a child or have children with ID, there's reduced employment and lifetime earnings. So this gets to the cost of the disabilities, and the cost is beyond just the cost of care for these children. The cost obviously impacts the whole family. We also have noted that adults with ID rarely experience paid employment. So if you reach adulthood, you still are, your economic circumstances are still impacted by the fact that you have a disability. So what is CDC's role in addressing these health disparities? So we do a number of things at CDC to try to address these disparities that we are aware of. We promote inclusion of people with disabilities in all of our CDC surveys, programs, policies, our communications. In addition to including them in our reports, we have standard disability identifiers in all of our HHS surveys. We have enhanced accessibility of about 90 interventions in our CDC community guide. We fund a network of 18 state disability and health programs. These programs focus on access to health care, health promotion, and emergency preparedness for individuals with disabilities. We also fund a network of public health practice and resource centers in order to reach the key populations with disabilities. So the importance of data on disparities, we see that we have data on disparities in the prevalence of developmental disabilities, and I demonstrated that by looking at Dds Overall, as well as looking at ASD, CP, and ID specifically. And then the question, we have data on health disparities and developmental disabilities and the impact, the health outcomes related to having a disability. We use all of this information to guide our future research, to plan for services and supports, and to develop effective interventions. In conclusion, disparities in prevalence exist among children with developmental disabilities. CP and ID disproportionately impact children who are male and Black. ASD is consistently higher among children who are male, white, and higher SES. So these are different patterns, but they still represent disparities. There's a need for more studies to examine the impact of other factors upon these disparities, as we were not able to control for everything. So an example is looking at access to services. And when we look at access to services, we need to think about what is misdiagnosis. What about health insurance coverage? That's a big one right now, and one that we have started to examine. What about cultural barriers in terms of the children who do see a healthcare provider. Some CDC studies show that children and young adults with DDs face health disparities, and we definitely need to conduct more research. Recognizing disability as a dimension along which health disparities occur presents an opportunity to reduce inequities and ultimately get people with disabilities the help that they need. So I'd like to acknowledge this big village that stands with me. It takes many individuals at each of our ADAM network sites. I showed you that we have 11 sites, and at each site we have a principal investigator, we have a project coordinator, we have abstractors, we have data managers. So each site has many people that are employed, and we have 11, and we also have a staff at CDC. They are all very dedicated, creative, hardworking, and resourceful, and I'm thankful to all of them. And special thanks go to some of my colleagues, Kim Van Arden-Braun, who is now with Hackensack Meridian Health, to Leah Chan and April Brown, who are at CDC, and to Maureen Durkin, who is at our CDC Wisconsin ADAM site. So this is how you can reach me if you have any questions or you want to contact me later about not just the presentation, but about opportunities at CDC. I'm happy to talk to you and explore your interests and encourage you to seek a career in public health. Thank you very much.